So my role this morning is to talk about new diabetes treatments and how the laboratory may be involved. So what are we talking about? Well, I want to focus on 4 therapeutic agents. We're not going to talk about thiazolidinediones or sulfonylureas. We're going to talk about the DPP-4 inhibitors, the GLP-1 receptor agonists, the SGLT2 inhibitors, and touch on the new basal insulins, where they fit in the new ADA EASD guidelines, and also where they may impact on the laboratory. And one of the things I will be touching upon is the new cardiovascular outcome trials, which have actually guided and changed the new guidelines quite a lot. And it was really based on this, which is the Steve Nissen publication on the effect of rosiglitazone on the risk of myocardial infarction and death in diabetes. And as a consequence, the FDA then mandated that all new agents had to have cardiovascular outcome trials. And basically the need to assess non-inferiority versus placebo and versus standard of care so that we can actually demonstrate that there was no unacceptable changes in cardiovascular risk for our new therapeutic agents. So what has changed? Well, what hasn't changed is that metformin is still the first-line drug of choice in the treatment of our patients with diabetes after lifestyle intervention. So let's talk about the DPP-4 inhibitors. As this audience knows, when you have a meal, the L cells actually get stimulated to produce GLP-1 and GIP, which then enter the circulation and therefore increase glucose-dependent insulin and reduce glucagon and therefore improve glycemic control. These agents are effective, modestly. They will reduce glucose. They're also weight neutral. They've got a very good side effect profile, and they are not involved in hypoglycemia. They are rapidly degraded in the circulation within minutes by DPP-4, and therefore the importance of a DPP-4 inhibitor that will maintain endogenous GLP-1. Now, what I want to talk about is 4 of the cardiovascular outcome trials associated with the DPP-4 inhibitors. That was saxagliptin in the SAVOR trial, alogliptin and the EXAMINE trial, sitagliptin in the TICOS trial, and linagliptin in the CARMELINA trial. And basically the results of these trials are shown here. And what you can actually see on the y-axis is the number of events, and obviously on the x-axis the actual time. And what I want to bring your attention to is the fact that in every single one of these trials, placebo and active are virtually identical. So what it basically shows is that whilst there was no cardiovascular benefit for the DPP-4 inhibitors, there's no cardiovascular detriment. The caveat to that was in the SAVOR trial, there was more hospital admissions for congestive heart failure with saxagliptin. Let's talk about the GLP-1 receptor agonists. As you know, that there's 2 broad groups of the GLP receptor agonists. There's the short-acting agonist, exenatide and lixisenatide, and the long-acting agonist that includes liraglutide, gelaglutide, abiglutide, semaglutide, and exenatide once weekly. Now, the additional benefits that the GLP-1 receptor agonists have, as I've mentioned, a DPP-4 inhibitor gives an endogenous physiological level of GLP-1. However, if you give a GLP-1 receptor agonist, you're giving a pharmacological level, and therefore you get the benefits and side effects associated with a pharmacological response. That includes the appetite loss, decreased food intake, and also the nausea and vomiting associated with these agents. What that means in real terms, and this is going back to the guidelines, that has been shown that if you have a GLP-1 receptor agonist and you add a DPP-4 inhibitor, there is no additional benefit. Conversely, if you have a DPP-4 inhibitor and you change to a GLP-1 receptor agonist, there's an improved glycemic response. So therefore, there's no benefit in combining a GLP-1 receptor agonist with a DPP-4 inhibitor. And this is also reflected in the side effect profile, because what you can see here is that the nausea, diarrhea, and vomiting is very low in sitagliptin. Obviously, it's a DPP-4 inhibitor orally given, whereas all the GLP-1 receptor agonists are much associated with increased nausea, increased diarrhea, and vomiting. And of course, they have to be given at the moment by injection. Now, what's been shown in all the GLP-1 receptor agonist trials is that these agents have a very good cardiovascular profile. In the main, they all reduce systolic blood pressure, they have a reduction in total cholesterol, and many of them have a decrease in body weight. The exceptions are probably glargine and abiglutide. One of the worrying aspects about these agents was that they all put up heart rate by around about 2 to 3 beats per minute. And you may be aware that in the past, sibutramine was the weight-reducing drug, also put up heart rate, and that was associated with increased cardiovascular events. Because of that, all of these drugs have actually had their cardiovascular outcome trials. What we see here is the Elixir trial with lixazenatide, the LEADER trial with liraglutide, SUSTAIN with semaglutide, the FREEDOM study with a new extended agonist, EXCEL with exenatide, and also HARMONY with abiglutide. The results to date show that, once again, rather like the DPP-4 inhibitors, is that with lixazenatide, there is no increase in cardiovascular events, nor is it cardiovascular protective. So it is a safe drug. And that's the same with the new extended FREEDOM CVO trial, and also with exenatide. There is no cardiovascular benefit, but there's no cardiovascular detriment as well. These drugs are safe. However, what I want to bring your attention to are the 3 trials that show cardiovascular benefit. And shown here are the forest plots. And what we've actually got is on the left, that favors GLP-1 receptor agonist, on the right, which favors the placebo. And this is liraglutide with the LEADER trial. And what you can see is that the major adverse cardiovascular event profile is improved by 13%, which was significant, mainly because of a reduction in cardiovascular death and the suggestion of a decrease in non-fatal myocardial infarction. However, when one looks at the SUSTAIN-6, which is semaglutide, you can see there's an improvement again in the major adverse cardiovascular events, and this has been driven by non-fatal stroke and numerically decrease in non-fatal MI. If one looks at HARMONY, again, there's an improvement in the major adverse cardiovascular events, and that's been driven by non-fatal MI. Now, what this means is that these 3 agents might have the same improvement in major adverse cardiovascular events, but they're acting perhaps in different ways. So each agent is not the same as the other. Now, commercially, you're going to have LEADER, liraglutide, and semaglutide. Abiglutide has been withdrawn from the market, and the reason is not because it wasn't effective, it's because one of the agents that did not reduce weight, therefore was a commercial decision. Therefore, from the laboratory point of view, how does this impact you? You may be aware that there's a concern of major increase in pancreatitis with the GLP-1 receptor agonists. And shown here is what happened in the LEADER trial, which happened in abiglutide, as well as semaglutide. And what you see is that whilst there's an increase in acute pancreatitis, both placebo and liraglutide, that there was no difference between liraglutide and placebo. What this means in real terms is that lipase and amylase requests should reflect the patient's setting and should not increase as a result of GLP-1 receptor agonist use. What about neoplasia? There was a concern about not only pancreatitis but pancreatic cancer. And again, showing here with the LEADER study, which was reflected in the other GLP-1 receptor agonist studies, is that there was no increase in acute pancreatitis over placebo, no increase in chronic pancreatitis. There was no increase in any benign neoplasm or malignant neoplasm, and there was no increase in either pancreatic carcinoma or medullary thyroid carcinoma. So in real terms, again, this means that the neoplastic risk in these new agents hasn't been an issue to date. It's early days. It requires constant surveillance, but it will not require an increase in any tumor marker requests. So now let's talk about the SGLT2 inhibitors. As you know, SGLT2 is responsible for the absorption of glucose in the proximal tubule. And basically, after inhibition, it promotes glucose renal excretion, and that is independently inhibited of the glucose concentration. And it doesn't depend on insulin secretion or sensitivity, but it does depend on the amount of glucose reaching the glomerulus and also the glomerular filtration rate. Now, what I want to do is concentrate on the actual cardiovascular outcome trials, again, from these three agents. We have the EMPA-REG with empagliflozin, and what you can see here is a decrease in the major adverse cardiovascular events, a decrease in cardiovascular death, suggestion of decrease in non-fatal MI, but numerically there was an increase in non-fatal stroke, although this was not significant. And if we look at canagliflozin, again, there was an improvement in the major adverse cardiovascular events, which was driven with a composite of improved cardiovascular death, non-fatal MI, and non-fatal stroke. But as you can see, none of them reached statistical significance. Conversely, if you look at dapagliflozin, dapagliflozin had no effect on any cardiovascular outcome measure, but at the same time was safe. The one thing that might affect the laboratory, those you're probably aware, is that these agents are associated with euglycemic diabetic ketoacidosis. It's really unclear if the rate of diabetic ketoacidosis is going to increase because of the use of GLP-1 receptor agonists. And it seems that this risk is particularly in those patients who are insulopenic, so therefore patients potentially with type 1 or LADA, and precipitated with the usual precipitants of surgery, MI, stroke, etc. These patients present in the normal fashion for diabetic ketoacidosis: pain, nausea, vomiting, fatigue, and dyspnea, with, in this case, either a normal or slightly elevated glucose. A low bicarbonate and urinary ketone would suggest the diagnosis, but direct measurement of blood ketones, specifically beta-hydroxybutyrate, and the arterial pH is necessary to confirm the diagnosis. And the management is that of normal diabetic ketoacidosis. So really, what we're going to see, I think that you are going to see is, in the laboratory, is that the number of patients in the acute setting in a hospital, you may be requested more arterial pH and beta-hydroxybutyrate requests in these sick patients, even if they don't have diabetic ketoacidosis. So now to put this into kind of relationship to the ADA-ESD guidelines, what you can actually see now is that those patients with the established atherosclerotic cardiovascular disease, the agents of choice are a GLP-1 receptor agonist or an SGLT2 inhibitor. First, the GLP-1 receptor agonist, and then to add an SGLT2 inhibitor. For those patients with heart failure or chronic kidney disease, then you may want to start with an SGLT2 inhibitor, then going on to a GLP-1 receptor agonist. And of course, in healthcare systems, these agents are not cheap. And those patients who haven't got established atherosclerotic cardiovascular disease, and you want to minimize hypoglycemia, then a DPP-4 inhibitor, GLP-1 receptor agonist, an SGLT2 inhibitor, or a thiazolidinedione would be appropriate. If there's a compelling need to minimize weight gain or lose weight, and let's face it, most patients with type 2 diabetes probably do need to lose weight, then a GLP-1 receptor agonist or an SGLT2 inhibitor. Where cost is a major issue, and I certainly see this in CATA dealing with the migrant population who have to pay 10% of their healthcare drugs, then a sulfonylurea and a thiazolidinedione are often the ones that they prefer because they are so cheap, and they are effective. So what happens when you actually have run out of oral treatment choices? The guidelines suggest that the most important thing is to add either a basal insulin or something that was going to reduce hypoglycemia. And then they suggest that injectables have to be intensified. And this is an excellent diagram. It shows that diabetologists will never be out of a job because it's so complex, no other discipline really wants to deal with it. The bottom line is this. It is now recommended that in patients who require injectable therapy, a GLP-1 receptor agonist is the preferred choice to insulin, unless patients have got uncontrolled asymptomatic hypoglycemia, where insulin is still recommended above a GLP-1 receptor agonist, and the two can be used in combination. And the evidence behind that is very interesting. Shown here is a forest plot, and it shows here the relationship, the comparison between a GLP receptor agonist and insulin, showing that the efficiency is the same, and that is either a short-acting GLP-1 receptor agonist or long GLP-1 receptor agonists, and all those agonists together. So in other words, we used to say that if you wanted to improve by the HbA1c by more than 1%, it either had to be lifestyle or it had to be insulin. And now we have a GLP-1 receptor agonist that do the same job without hypoglycemia. So I want to touch now on new basal insulins, which are commonly being used. The first I'll talk about is degludec, which is basically insulin, which has got a glutamic acid spacer and a C16 fatty acid attached to it. This is in a dihexamer formulation with phenol, and once it's in the actual subcutaneous tissue, it then dimerizes, then forms these multihexamers that slowly are absorbed into the circulation. What that actually gives you is a nice flat time action profile over 24 hours, which is a peakless insulin and therefore does not or has reduced hypoglycemia. Sanofi Aventis have found that if you concentrate glargine in polyethylene glycol, so you've got the U300 preparation, then this also delays absorption, which also gives this kind of nice flat time action profile, which lasts 24 hours. Now, until recently, there's always been concern that insulin may be associated with cardiovascular death and outcomes, and that's been put to rest really now with the DEVOTE trial. And what's basically shown here is after 9,000 patients in 5 years, that a direct comparison of insulin degludec versus insulin glargine U100, there was no difference in the cardiovascular rate, and that one drug, one insulin, was not inferior to the other, suggesting that there was no increase in cardiovascular events. However, what was shown is that with these new insulins, these new flat time action profiles, in this particular case, there was a significant reduction of 40% of severe hypoglycemia and a 53% reduction in nocturnal severe hypoglycemia. This study was particularly limited because it did not look at minor hypoglycemia, so we can't actually see whether or not that was improved over the 5-year period. In summary on the insulins, new long-acting basal formulations of degludec and the glargine U300 may be comparable in the first instance with a reduction of hypoglycemia. However, there's no additional impact on glycosylated hemoglobin over and above that of glargine U100, although there's an improvement in nocturnal hypoglycemia by around about 25 to 36% over insulin U100 glargine, which of course had a 26% improvement in hypoglycemia over NPH, if you remember, in the Origin study. And the longer-acting preparations may have more advantages for dosing flexibility for patients who can't take their insulin at the same time and without compromising safety. So will there be a need for more laboratory monitoring, which is why I'm here? And basically what I'd like to bring your attention to is firstly metformin. And the reason is because metformin has been pushed and pushed and pushed, as you know, as the first-line therapeutic option for the treatment of type 2 diabetes. We do know that chronic metformin treatment leads to B12 deficiency in 30% of patients, and we also know that there's the exhaustion of B12 stores after 12 to 15 years. We know that B12 deficiency is associated with neuropathy, but what is not clear, and the studies still have not given us the answer, if there's an association of the depletion of B12 due to metformin and the development of neuropathy. However, increasingly, there's a push now to actually for the regular measurement of vitamin B12 status. And the 2018 American Association of Clinical Endocrinologists and the American College of Endocrinology have suggested to monitor and treat B12 if neuropathy develops, but hasn't gone as far as saying regular monitoring is required. So I think there's likely to be an increase in B12 B12 requests, even if these are not going to reflect in clinical practice of B12 replacement. So the final thing I want to talk about is there going to be a need for increased renal monitoring with all these new agents? And what I'd like to bring your attention to is, firstly, in those patients treated with insulin, yes, you have to treat them with caution, irrespective of the state of the chronic kidney disease. In the past, metformin has been stopped with CKD grade 3B, so an eGFR less than 45 has been associated with a reduction in metformin. There are many countries now, it's not universal, but there are many countries where this limit has now been reduced so that metformin can be continued down to an eGFR of 30. Looking at the SGLT2 inhibitors, this is going to be an old slide, probably in 12 months' time, and the reason is because, as you can see, it's recommended that the SGLT2 inhibitors, the dose is reduced or stopped with dapagliflozin with CKD grade 3A. But increasingly, you're probably aware that there's a number of reports showing the renal benefits of SGLT2 inhibitors, and therefore it may well be that the recommendations for when these should be stopped are going to be altered as well. With the DPP4 inhibitors, great drugs. To be perfectly honest, most of the time you don't have to reduce the dose, and certainly you don't have to reduce the dose with linagliptin at all. And for the GLP-1 receptor agonists, again, this is probably going to be an old slide, and the reason is because there's increasing evidence to show that the GLP-1 receptor agonists are safe and lower levels of renal dysfunction, and probably down to below CKD grade 3A. So in summary, what I've shown you is that the diabetes therapeutic agents will not increase the need for more biochemical measurement for renal function. So in conclusion, ladies and gentlemen, the new agents don't come with an increased workload for you, for eGFR management, for any markers of cardiac dysfunction. There's no going to be increase in pancreatic markers with GLP-1 receptor agonists. There's not going to be an increase in tumor marker requests. There is probably going to be an increase in requests for vitamin B12, even if clinicians then don't replace or just ignore the results. And there's probably going to be a request for inpatient arterial pH and beta-hydroxybutyrate for those inpatient diabetes patients on SGLT2 inhibitors. Thank you for your attention.